All right, everybody. So welcome to our update on COVID-19 and the older adults. We're going to take a tour through the current research and then pass through sort of an interprofessional dialogue as to what the different specialties, different professions are doing in the time of this pandemic, their thoughts on barriers, their thoughts on solutions, and a detailed reminder about the social determinants of health and the cultural determinants of health, and important aspects of mental health of older adults during this very difficult time. So we have a whole panel of people that are going to be speaking today, starting with our geriatric medicine fellows, Dr. Kyrillos Iskander, Dr. Andreas, and Dr. Masad, taking a look at the evidence, epidemiology, and treatment of this terrible illness. And then our psychiatry resident, Dr. Yancey, is going to take a look at the effects on mental health in older adults before we pass on to nursing perspectives for the pandemic, barriers and solutions, social determinants of health in a changing world, where our social workers, Margaret Salmuri, Clivia Torres, and Yiting Chang will give us a summary and some guidance on paths to keeping our older adults safe at home. And last but not least, the cultural and social implications of the pandemic on our aging community and on aging in our society. Dr. Taylor is going to speak on that. And here we are. So Dr. Andreas, I'll let you take over.
Hello everyone, thank you Dr. Reinhardt. Can you hear me well?
Speak a little louder, yep.
Okay, so we're going to start with the epidemiology. Can I have the, how do I switch the slides? Okay, thank you. So let's start from the beginning. In December 8th, the first patient developed symptoms in Wuhan. That seems like a new virus. In December 31st, China alerts WHO about several pneumonia cases. In January 1st, the Wuhan's wholesale seafood market is shut down. And in January 7, the virus is identified as a new virus. As we know today, it's COVID-19. In January 11, the first death in China is reported. In January 13, the first case outside of China is reported. In January 14th, WHO warns of risk of human-to-human transmission, and risk of a possible wider outbreak. In January 20th, the virus spreads to US. The first confirmed case is a 30-year-old male who had returned from a trip to Wuhan. In January 23rd, Wuhan is placed under quarantine. The rail and air services are suspended. And in January 29, the death toll climbed to 132 with 6,000 new cases reported. In January 30th, the public health emergency is declared. In January 31st, US restricts entry by any foreign national who has traveled to China in the previous 2 weeks. On February 11, COVID-19 is named. In February 29, the first death in US is reported, but as we know today, actually going back to the deaths that were before we were aware of COVID-19, apparently the first death in the US was in February 6th in California. In March 11, WHO declares it pandemic and US restricts entry from countries from Europe. And in April 10th, the death toll passes 100,000, doubling every week. So where we are today, as you can see on the map, the virus is basically everywhere in the world. As of this morning, there is a total of over 3 million cases confirmed worldwide, with over 200,000 deaths. In US, there are close to 1 million confirmed cases with over 5,500,000 deaths, trailed by European countries that were hard hit and that had more cases and more deaths per capita than US currently. So in US, The virus hit mostly the East Coast, as you already know, the West Coast, and almost all major metropolitan areas. As of this morning, New York had 293,900 cases. New York City, about 160 cases, and 22,000 deaths in New York State, with almost half of them in New York City. The second hard hit state is New Jersey, with about 100,000 cases confirmed, with 5,000, almost 6,000 deaths. Then Massachusetts, Illinois, and California. So let's talk a little bit about the virus. The coronaviruses are positive single-stranded envelope RNA viruses belonging to the family Coronaviridae. The name is derived from the Latin corona, which means crown, due to the crown-like projections of the protein S, the spikes of protein S seen under electron microscopy. It's usually causing common infections in birds and mammals, with causing gastroenteritis and respiratory infection. There are 7 coronaviruses that have been identified as causes of human disease. Usually they cause seasonal cold, but some of them cause pretty severe respiratory tract infection. One of them is the severe acute respiratory syndrome caused by SARS-associated coronavirus, likely of bat origin. It spreads by airborne droplets and was first reported in Southeastern Asia in February 2003, responsible for the SARS pandemic in 2003. The second one is the Middle East respiratory syndrome, also called MERS, caused by the MERS-associated coronavirus. Its host seems to be the dromedary camels and was discovered in 2012 as a cause of severe respiratory illness in the Middle East. And it's responsible for the MERS pandemic. And the topic for today, the COVID-19, which we're gonna talk in a few minutes. So in terms of what the virus does, after entering the body, the virus gains access to the human cell by binding to the angiotensin receptor 2 that's present in the respiratory epithelial cell as well as in gastrointestinal cells. Then it's hijacking the cell machinery in order to produce more copies, and it's releasing multiple virions in the human body, taking over. So the COVID-19 disease, as I already said, it was first described in Wuhan in late 2019. The origin is still uncertain, and it's debated, but it's likely from bats, as we know now. 96%, they found a 96% similarity with a bat SARS-like coronavirus. It affects mainly adults. The median age is 59-year-old, with about approximately 60% being males. And there are fewer identified cases among children and infants. The population most at risk seem to be people with poor immune function, such as elderly, and those with renal and hepatic dysfunction. In terms of transmission,
Dr. Andreas, just say next. I'm controlling the slideshow when you're ready to advance.
Okay, thank you. In terms of transmission, there are 2 main known modes of transmission. One is droplets, which spread directly by the infected person. The second one is contact, due to droplets falling on surfaces and people getting infected from touching the surface and self-inoculating by touching their face. There is also a third mode of transmission through aerosols, which has been described in certain conditions, but it's still considered to be secondary to the previous 2. What we already know is that the virus can persist on surfaces, such as plastic, up to 6 days, depending on temperature, humidity, and inoculum size. And it's easily inactivated by disinfectants, such as alcohol and bleach. And the infection has been described in animals, but there are no reports of domesticated animals transmitting the virus to the humans. Next, please. Because at this time we have no proven treatment for COVID-19, prevention becomes of major importance. As you all know, by now preventive measures such as avoiding close contact with people who are sick, avoiding touching the eyes and nose and mouth, isolate at home if symptoms are present, cover the cough and sneeze, clean and disinfect frequently touched objects, wash the hands frequently for more than 20 seconds. In addition, most areas of the country are currently under stay-at-home orders, and the recommendation for wearing masks in public was already implemented. Next, please. In terms of prevention in healthcare setting, there are multiple recommendations. One of them is screening patients for COVID-19 symptoms prior to entry into a healthcare facility, management of mild infections and triaging through telemedicine, restricting visitors to healthcare facilities, screening for symptoms and isolating healthcare personnel that has symptoms, universal use of medical masks and 95 respirators if they are available, surgical masks and PPE, use of standard contact and droplet precautions of all patients with respiratory symptoms, using an airborne infection isolation room for aerosol generating procedures and treatment, recommending that patient wear a mask if transported out of their room, and because of the PPE shortages, optimizing the supply of PPE through canceling non-urgent procedures or visits, limiting movement outside of patient room, prioritizing PPE use for the highest risk situation, designating COVID-19 units, and minimizing face-to-face encounters, limiting the number of people who examine a patient, using medication with extended intervals, and allowing some providers to perform telephone encounters. So the main goal for all these prevention measures are to flatten the curve, because first of all, we stop the spread of the virus. As you can see, the exponential curve seems like it's already flattening. And also because we need to not overwhelm the healthcare facilities that need to take care of those patients that get the serious disease. Next, please. And our ultimate goal is to obtain herd immunity. In the absence of a treatment, our best bet for protecting the vulnerable population is achieving herd immunity, which, as you can see, compared to an unimmunized population, where the virus spreads easily, a 50% immunized population has a more limited spread. And eventually, in a 70% immunized population, the vulnerable people would be protected because the infected person would not be able to spread the virus to other people. So that's the main goal as far as now, because we don't have a treatment. And this is the principle that applies also for the virus, for the vaccinations.
Hello, everybody. I'm Dr. Masad, one of the geriatric medicine fellows. I'm going to talk to you about the clinical presentation, manifestations, a bit of the underlying pathophysiology and diagnosis, and I'll take it to Carlos, who will discuss management. So much of these studies that I've sifted through come from China, Wuhan, Italy, and some characteristics from some studies in New York City. The incubation period usually occurs, the incubation period is the time of exposure to symptom onset. It occurs within 14 days of exposure, majority of being 4 to 5 days. In a study of about 1,000 patients in Wuhan, the median incubation period was 4 days. In the same study, there's a wide spectrum of symptom severity, majority being mild or asymptomatic. This is about 81% of cases. In severe disease, those with dyspnea or shortness of breath, hypoxia or low oxygen, that's about 14%. About 5% of these patients become critical, whether they have vasodilatory shock, multi-organ failure, and the case fatality rate at that time of the study was about 2.3% in China. The risk factors for having severe disease, including cardiovascular disease, obesity, hypertension, COPD, chronic kidney disease, and diabetes mellitus. And pertaining to our patients, older age is one of the highest risk factors for increased mortality. For example, in Italy, the case fatality rates were 12%, ages 70 to 79, and 20% for those over 80. Next slide, please. So most of these studies describing clinical manifestations are in hospitalized patients. These are the patients coming in, getting tested. There's a significant amount of asymptomatic patients. This number is not known. I'll go into that shortly. In this small case series of 138 patients in Wuhan, China, most of the common manifestations were fever. It supported about 99% of patients, fatigue, dry cough, lack of appetite, myalgias, dyspnea or trouble breathing, and increased sputum production. There are some interesting symptoms, anosmia or a lack of smell, dysgeusia or change in their taste. That was a common complaint amongst patients. They did one survey in Italy, 59 patients, 34% had either a loss of smell or taste, and 19% reported both. Another symptom that patients may present with are GI symptoms, gastrointestinal. There's a meta-analysis, about 4,000 patients. I believe there's 20 to 30 studies, most of which are in China. The prevalence of these symptoms, nausea, diarrhea in particular, was about 17.6%. And of these patients, they sampled 48% of the RNA from the stool samples. Next slide, please. So I mentioned asymptomatic infections, and the exact frequency is unknown, but more and more studies are coming out where we're getting an idea or a sample of how much of these asymptomatic infections there are. And it's important because it gives us more data on what the exact mortality rate is, as well as how far spread this disease or this infection is. I'm sure you guys remember the Diamond Princess. That was an outbreak on a cruise ship. These cruise ships tend to be floating petri dishes. Nearly all the passengers were screened, including crew members. And as of February 20th, 17% of them tested positive. And half of those confirmed cases were asymptomatic at the time of diagnosis. Now, more of those patients may have developed symptoms, but as of that time, half of them were asymptomatic. I'm sure several of you heard this study of the universal screening program of pregnant women in 2 New York City hospitals. They screened 210 asymptomatic women. 29 of those had tested, which is 14%, had tested positive with the PCR test. 4 additional women did develop fever that tested positive. So of the 33 women in total that tested positive for coronavirus, 88% were asymptomatic at that time. Next slide, please. I think there's a part missing here. But there was a New York City study about 5,700 hospitalized patients in the Northwell Health System. This serves New York City, Long Island, and Westchester. And this is the time between March 1st and April 4th. They gave the case series of these patients. If you look to the top right, what I found most interesting about this study is they did triage vitals at the time of these hospitalized patients. About 30% of them, only 30% of these patients were febrile at the time of presentation. Now, this could be a multitude of factors. They may have developed fever later on in the hospitalization. Did they take Tylenol? Some elderly patients also sometimes don't show up as febrile. About 20% were hypoxic, had a O2 saturation less than 90%. And about 43% were tachycardic, the heart rate of greater than 100. Most of the common comorbidities were hypertension, 56%, 41% of these patients were obese, Diabetics constituted 34%. During hospitalization, 14% required ICU level of care, 12% required mechanical ventilation. And one of the shocking figures of this was that 88% of those ventilated patients had died. Mortality rates for those who received ventilation in the 18 to 65 group was 76%. And if you're older than 65, it was a 97% mortality rate for those who were mechanically ventilated, intubated. Now, during the study, it was between March 1st and April 4th, so not all the patients had a disposition yet, whether they were discharged or had died. It was about 2,800 patients, so it may vary what the total number ends up being. The mortality rates for those who were not ventilated were very different, about 20% in the 18 to 65 group and 26.6% in the older than 65 age group. And if you look at the graph on the bottom right, you can see the varying mortality rates of those in different age groups. You can see in 60 to 69 is about 18%, 70 to 79 is 35%, 80 to 89 is about 60%, and over 90 is about 63%. Now, this is of patients who had a disposition at the time of the study. And the other interesting note is that female patients had a much lower mortality rate than male patients. Next slide, please. This is from JAMA. This is from Italy in mid-March. This is some of the data we received. Again, cases by age range, about 37% were over 70, majority male, as Laura had told us. It's about 60% male. Majority of cases are mild, about 46%, 25% being severe. But the case fatality rate, as you can see, when you get higher up in those age groups, it starts accelerating. 60 to 69 is about 3.5%, and then we get up to over 70, get 12%, then 20%, and then 23% for over 90. Next slide, please. So the median time to hospitalization was about 7 days after symptom onset. As Laura had mentioned, ARDS is the major complication. In this same study in Wuhan, it occurred in about 20% of patients admitted, occurring after a median time of 8 days. 12% of these patients are ventilated. There's lots of complications, and I know more complications are coming out in the news. We're hearing about strokes in younger patients, thromboembolism. We're hearing cardiac injuries, kidney injuries, even some cases of Guillain-Barré syndrome. According to the World Health Organization, the recovery time is about 2 weeks for mild disease and can be up to 4 weeks for more severe infections. So some common laboratory findings for these hospitalizations. One thing is the lymphopenia. In about 400 patients in New York City, 90% had a lymphocyte count of less than 1,500. That seems to be something characteristic of this disease. Elevated transaminases, which are liver function enzymes, LDH, inflammatory markers, ESR, CRP, IL-6. IL-6 will be important, as I'll allude to, as well as Kirlos, and elevated D-dimer. These inflammatory markers are hypothesized to be part of a dysregulated inflammatory response called the cytokine release syndrome, which I'll talk about shortly afterwards. Next slide. So just quickly about imaging, chest x-rays might be normal in very mild disease. Usually the abnormalities associated are consolidation, like a pneumonia type picture. What we call ground glass opathies is a characteristic radiologic finding. And they tend to be the worst after about 10 to 12 days of symptom onset. CAT scans are more specific, but the official response of the ACR is that they need to be reserved when it changes management, so no routine CAT scans. And these peripheral bilateral ground glass opathies are typical, with or without consolidation. I'm going to briefly talk about the pathophysiology next. Next slide, please. Some of these slides appear to not transfer properly. Anyway, so there's supposed to be some words here, but This picture is denoting what's called the cytokine. You can keep it on the slide. The cytokine release syndrome, and this syndrome is more characterized in cancer patients on immunotherapy or CAR T cell therapy, but it has been shown in SARS as well as MERS, and it's hypothesized to be part of COVID-19 as well. And what happens is the virus comes into the alveolus, which is the lowest part of the lungs, the air sacs. They bind to the ACE2 receptors. The innate immune response takes over, macrophages, and this storm of inflammatory markers and a cascade ensues, and that gets affected systemically and causes this what we call cytokine release syndrome, or this dysregulated immune response. Next slide, please. So again, this slide was supposed to have some other words and graphics on it, but I don't know what happened to it. That's okay. I can manage. Oh, there it is. So in the Lancet, an interesting case reports of a postmortem histologic analysis of several patients showed evidence of direct viral infection of endothelial cells, causing endothelial inflammation and apoptosis of these cells. They described 3 patients. And the ACE2 receptor, which we keep talking about, is also expressed on these endothelial cells. And it's expressed through a multitude of organs. It's not just the lungs, it's also in the liver, Laura mentioned the GI tract. And this inflammation of the endothelial cells may be why there's such a high rate of thromboembolism, why strokes might be occurring in some patients, heart attacks or myocardial infarctions. So we're still trying to figure out exactly what's going on. You can see on the slides, there's a perivascular infiltrate of inflammatory cells causing these complications. Next slide, please.
There was just one question from
Sure.
Joel. Any sense that patients with renal problems may predispose to infection based on ACE2 upregulation?
So
do you want me to answer that, or do you want to answer that, Steve?
Well, there's been some update or some debate about taking ACE inhibitors, angiotensin blockers as well, whether the upregulation of these cells causes a worse response. I don't know if Kirilos has anything to say about that in particular. I think he does discuss that.
So I'm going to be talking about
it.
Yeah,
sure.
Okay.
But my evidence, I didn't see any evidence of that.
Right, exactly. So there's no, like just like Steve said, so like just because it's part of the supposed pathophysiology, there's no indication. Like if the patient is on an ACE inhibitor, like the ACC and other societies have recommended that they continue the ACE inhibitor. It's not an indication to stop ACE inhibitor treatment.
Correct.
Like if there's an indication for it, they should be on it.
Yeah.
It's like there's no evidence at all to suggest that being on an ACE inhibitor worsens outcomes. And like the counterpoint, so ARBs, theoretically, if you look at the pathophysiology, should be protective, but you would never start an ARB to like prevent the virus.
Right.
Does that answer your question, or?
He says yes, thank you. And one more question from
Sure.
Shirley Gerard, and this may be for all of the geriatric medicine fellows. Given high mortality rates for those on ventilators, why would anyone agree?
Right. So that's another good question that I'm going to talk about. So that's a really good point, right? So like there was the initial reason, like the initial paradigm was we should intubate everybody, early intubation, whatever, right? And there's multiple reasons for that, not just like to save people, but also because, putting someone on non-invasive ventilation or on high flow, like aerosolizes everything, right? So like a lot of these bigger centers were just intubating everybody once they like had an oxygen requirement above 6 liters. And you're right. So obviously, like, if you're talking about the general population might not know. They might think that, like this is going to save my life, whatever. But you're right. I mean, like if they had known, had they like about the mortality, which they didn't initially, obviously like jumping to intubation was a very, very bad idea. Because even if you look at Steve's slide, there's an 80% mortality.
Yeah.
So I don't know if that answers it.
Some people are discussing what's called permissive hypoxia, even letting these patients go more hypoxic before intubating them and mechanically ventilating them. But we're learning more and more about this every day. The initial recommendations according to the critical care societies, did recommend possible early intubation and to avoid non-invasive, as Carlos said, because of the risk of aerosolization. But we're learning now more that once you're ventilated, the prognosis is
right.
poor. And it's still a last ditch effort, and you're not intubating everybody who comes in with coronavirus. That's you're already in bad shape if you are being intubated.
Yeah, exactly.
So that's
like
the other side.
And that's that was the thing. That was the initial paradigm, was that like early intubation saves lives, and early intubation didn't save lives. So now the paradigm is give as much non-invasive as possible. Like obviously balancing the risk to staff as well as the the patient risk. And then really when they're like essentially like at the end of what you can provide non-invasively, intubate.
Thank you, Carlos. Shall I move on? Any more questions? We're good?
That's it for the time being.
Okay. So diagnosis is pretty straightforward. You're just trying to detect the viral RNA through PCR. The CDC recommends a nasopharyngeal swab. It's really uncomfortable. Oropharyngeal and sputum are acceptable, probably not as sensitive. If the patient is ventilated, they recommend lower tract specimens and bronchial washings, essentially. False negatives are well documented, and now the vendors have their own sensitivities, but it really depends on the type of assay, the specimen, whether it's nasopharyngeal or oropharyngeal, the quality of collection, and also the course of illness at the time of testing, whether they were tested early on or later in the course of disease. In this small study in China, 51 patients who ultimately had coronavirus, about 29% had an initial negative test. In a Singapore study, they had an 8% initial negative test. So if you have a strong clinical suspicion, usually they recommend at least 2 tests. Serologic tests, I'm not going to go into right now. It's not as useful in acute infections. It takes time to develop those antibodies. Testing for other virus, influenza, RSV, parainfluenza, those are important diagnostic workup. Now, just because you test positive for influenza doesn't mean you're not going to test for positive for coronavirus. There are cases of co-infections. The CDC and IDSA, which is Infectious Disease Society of America, released priority testing. That's on the next slide. We're probably still in the first priority section. We're generally saving these for hospitalized patients and symptomatic healthcare workers. These are the first priority of testing, depending on testing availability. Second would be patients in long-term care facilities, nursing homes, people who are high risk, usually patients who are over 65, people with underlying conditions, first responders. I'm not going to go through every one of them, but the last priority would be testing individuals without symptoms. And this would be more of a community surveillance, public health priorities, which is something we hopefully get forward into. Next is going to be Carlos Iskander. I'll leave it for him.
Hi, how are you? My name is Dr. Iskander. I'm a third geriatric fellow. So let's start. I divided this into 2 parts. Actually 3. The first part is the respiratory care, and the second part is what we do supportively, and the third part is like what the investigational drugs are. But I do want to start, like if I can, by asking, what have people heard about like management and treatment options? Like specifically relating to respiratory care, if anybody has heard anything. Because I just want to say a lot of this stuff is like not like set in stone. There's not a lot of data. So sometimes, observation or, clinical, like what you've done clinically is, could be more useful than the scant data we have for any of these things. So just a general question, if anybody's heard anything specifically about intubation, BiPAP, high flow, or so on.
So
So
please
I've
feel.
heard about
Yep.
how do we pronounce it? Remdesivir?
So remdesivir,
as
yeah.
a
So
possible
just let's
treatment?
specifically talk about
So,
respiratory care, but you're right. Yeah, remdesivir is.
And so I know that we're now a part of a pilot. We initially tried to get access to this through compassionate use, but I guess now we are formally part of the pilot study, so they are rolling it out.
Right. And what have you heard about remdesivir specifically? Like, have you heard any good outcomes or specific cases?
That it's promising, but still, like, there's not enough data to have it sort of conclusive, which is the reason why Gilead is still holding on to it.
All right, perfect. And I read down here somebody talked about
And
proning.
they want to, of course, make sure that they put out the best product in terms of the long-term sales.
Right, exactly.
So.
Exactly. And the thing I find too with a lot of these treatments is like, did the virus self-resolve or did the treatment help? It's hard to tell sometimes. But yeah, I read somebody put in the comments about proning. I don't know if whoever put that just can comment on that.
That was Min.
All right. I think he just responded.
Feel free to unmute yourself, Min, if you have anything to say, or if it was just a general comment.
If you wanted to discuss the prone positioning,
Right. So all right. Yeah. Okay. I mean, that's a good suggestion. Proning, right? So, so proning's an interesting one. I'll talk about it later. But usually proning's done in ARDS, specifically when somebody's intubated. But I've also heard cases where people are fully conscious on some like modality like high flow or nasal cannula, and they prone and they improve. So yeah, that's another interesting. And I've done it myself actually to some good effect. So interesting. Anyway, so let's start. So respiratory care. So I divided it sort of half and half. I'll start talking about the care in non-intubated patients, and then finally how to escalate care to high flow, BiPAP, and then ultimately when to intubate. So usually we start off with a simple modality like nasal cannula or simple mask. Those usually max out at 6 liters per minute. So if for example you put someone on a nasal cannula and you crank up the oxygen to 15, they're still going to get 6 liters per minute. They top off at that. So once you get to 6 liters, then you want to escalate a little bit. You want to escalate to non-rebreather and Venturi mask. Venturi mask we don't have, so let's just talk about non-rebreather, where you can deliver a significantly higher amount of oxygen, so 20, 25 liters. And you want to target these patients to a target O2 sat of 90 to 96, and you should titrate down whatever you're giving. So if you're giving nasal cannula, if you're giving a simple mask or non-rebreather, you want to titrate down the flow rate to get to basically your goal with the lowest effective flow rate. You don't want to over-oxygenate. As Steve said, like there's some evidence for permissive hypoxia in the pathophysiology of this virus. Next slide. All right, so this is where the controversy comes, right? Do we do non-invasive ventilation, so BiPAP or high flow, or do we intubate early? So as Steve showed really well in that initial study, the rate of mortality on intubated patients was dreadful, and that was cohorting people that had been on non-invasive and people that were early intubated. Intubation is just not a good modality for these people, and I think because the pathophysiology is not fully understood, so we believe that there's some component of ARDS, but there's also a significant component of vasculitis. A lot of patients that were intubated on the ward that I was working on were on like very low ventilator settings. So it's unclear what this rapid like turnaround into like respiratory failure is, but it's not fully understood, and somehow early intubation and even like intubation specifically can worsen the outcome. So the way we did it, which ended up being the recommendation was we would max out all non-invasive modalities before intubating. So I put a lot of patients on BiPAP, a lot of patients on high flow nasal cannula, and basically watch them. If there was improvement, and we could titrate them back down to like non-rebreather or high flow, we would do that. And a lot of them did actually come off these like escalated therapies and, you know, were ultimately discharged. But obviously you have to keep a very close eye on these patients, right? Because they could turn around in a second. We had a couple on BiPAP and, you know, a couple on high flow that essentially decompensated rapidly and ended up getting intubated. So the recommendation is cautious use of these modalities and balancing the modality with the risk of like staph harm, right? So you also don't want to, you know, have an open room or not have PPE and be going to a BiPAP person's room with aerosols everywhere, right? So, so that's really the thought now. Next slide. And I mentioned about my observations, right? So, like I said, the way we did it on our unit, and let me just say, so all these places that were early intubating people, these were very wealthy hospitals in like Manhattan that had the resources and the rooms and then, you know, negative pressure rooms and all these things to protect themselves and protect staff. Okay, so in a resource poor hospital like ours, if we had implemented that strategy of intubating everybody, we essentially would have run out of ventilators and run out of ICU beds. So part of the reason I had implemented that strategy on this unit was to flatten the curve for the ICU, because if everybody was getting intubated, they would also be overwhelmed, like staff-wise, bed-wise, and resource-wise. And it ended up like actually being beneficial to a lot of these patients. I'd say, based on my observation, we probably avoided, I would say, 95% of intubations by using some non-invasive modality. So that's just my observations. And again, don't take that with a grain of salt. It's just what I experienced over the past month managing these patients. Next slide. Any questions so far at all about this before I move on to supportive care? Everyone good? All right.
I want to ask about tocilizumab, but I think you're going to discuss that later, right?
Yeah, I'm going to discuss it soon.
Okay.
All right. So,
Dr. Kirlos.
Yes.
Hi, this is Dr. Prosper.
Okay.
So, the protocols that were used initially, what was the approach in terms of what was the evidence to support it? It was obviously something, right?
So a lot of the evidence was based on observations in China, observations in Italy, which again, all those studies too were very, very flawed in a lot of ways. They were like very preliminary studies showing possible benefit here, possible benefit there, and again, like also like even if you look at China and Italy, their population doesn't match ours. So in our population, for some reason, not intubating and maxing out non-invasive oxygen therapies was beneficial. At least that's based on my observation and really what the Critical Care Society is now observing as well. So I'm not sure. I think like at a time of crisis, you get a lot of like panic, articles and panic ideas and stuff. And I think a lot of what we learned for our community, which is largely African American, and unfortunately who suffer the most from this virus. So a lot of it like was learning just by trying, you know what I mean? So I'm not sure. I think a lot of it was flawed data from other places and too rapidly implementing them. And a lot of it too was fair concern for staff safety, right? Like if you intubate someone, you have a closed system and you have a decreased rate of aerosol, right? So I don't know. I don't know if you have anything else to add, Dr. Prosper.
No, I thank you for that response. It is true. We obviously practice evidence-based medicine. And aside from what came out of maybe China, a lot of it was also based on how we would approach treating acute respiratory distress syndrome secondary to other agents or other initiating factors. So we tried to apply it to this SARS coronavirus. Part of it was investigational though, because this is new to us. So
exactly. And I think it's hard to compare. I mean, like even if you look at, for example, China's numbers, China's not accurately reporting numbers, and Italy had like exceptionally poor like outcomes for their patients. So it's not clear what worked and what didn't. Like Italy basically reflected like a total collapse of their healthcare system. So it's really hard to tell. Like a lot of what I did is exactly what you said. It's just like, what would I do for someone in CHF exacerbation? What do I do for someone in COPD exacerbation? Like would I intubate them right away? No, I'd probably try like high flow. I try BiPAP. I try something else. Anyways, so moving forward. So just a little bit about the, what supportive care we should do. There's always a question about what we should do about IV hydration. Should we give these patients fluid? Like, obviously, if they're dry, if they clinically, give them fluids, but don't like routinely give like 75 cc's of NS or LR to these patients. It's actually much better to keep them dry. If they're fluid overloaded, they have excess fluid, the severity of ARDS can be significantly worse. So basically use a conservative strategy and give, for example, PRN boluses instead of using continuous fluids. And then this is an interesting one. So like Steve said, there is a significant degree of thromboembolism in these patients. They did actually even autopsy study on the lungs of these patients, and almost all of them had some evidence of microthrombi in the lung. So at a minimum, every patient, like even if they're young and walking around, should be on DVT prophylaxis. Now, like the question, comes about, do we give these patients treatment dose Lovenox, right? So some centers and some, ICUs, they'll put anybody that's intubated on treatment dose Lovenox to treat these microthrombi. Some centers, if you have a very elevated D-dimer, so if your D-dimer, is 600, like 3 to 5 times the upper limit normal, you get full dose Lovenox regardless. And that is essentially what we tried to implement as we moved, through this like peak. And it's hard to tell because you put these people on a lot of different treatments, but we had relatively good outcomes in the patients that we started full treatment dose anticoagulation. And then moving forward, obviously, like everything else should be done, like medicine-wise. You control their sugars, and early PT and so on. Okay, so another question that I hear a lot is, should we treat for bacterial pneumonia, right? A lot of these patients coming in have fever. You do a chest X-ray. Chest X-ray shows a multifocal pattern of pneumonia, and that's almost indistinguishable from bacterial pneumonia. So the question is, do we treat or do we not treat for bacterial pneumonia? And that question is not easy to answer. So the way that we would do it is we would get an initial procalcitonin, treat empirically for bacterial pneumonia, and then trend the procalcitonin over a day or 2 days. If the procalcitonin was downtrending or was basically lateral, we would stop the antibiotics. If it was uptrending, then that would sort of push us to say, it's probably COVID, but maybe it's COVID plus a bacterial superimposed pneumonia. Use it in that respect. And then again, obviously, if you're gonna give antibiotics for bacterial pneumonia, you want to get blood cultures, sputum cultures. You want to rule out Legionella, which can also present similarly. So next slide.
I'm sorry, Dr. Carlos.
Yes.
Just to bring us all to the same page, what's the procalcitonin, or how will I know when to initiate and when not to?
So procalcitonin, so you're talking about the level specifically, or what procalcitonin means?
Yeah, the level.
So the level, so any procal below 1 is very, very convincingly viral pneumonia. If you go to 1.5, then maybe there's a little bit of a bacterial component, or it could be bacterial pneumonia. Above 2, in the absence of renal failure or CHF, is sepsis. So there's definitely a bacterial process going on, and the patient probably has like a full blown septic picture instead of like an isolated just pneumonia. Those are the cutoffs that I used.
Thank you. So the procalcitonin level is elevated in bacterial pneumonias. Bacterial
pneumonia, and then sepsis is very elevated. But the only exception is in renal failure. The procal is going to be chronically elevated because procal is cleared renally. And then in patients with severe CHF, they also have a falsely elevated procal that may not reflect like a sepsis or pneumonia.
Thank you.
Yeah, so just like I said, so what's important about the procal is not one isolated figure. It's actually to trend it. So you could have like initially in a disease process, you could have low procal, and that as that progresses over several days, you can have an uptrend. So you really want to look for a pattern. If the initial procal is less than 1, you repeat it the next day. If it's around the same level, then that's pretty convincing that this is just pure COVID, no additional bacterial issue. All right. Next slide. Okay, so there was a lot of, pandemonium about the use of Nsaids. So obviously there was, some recommendation that Nsaids shouldn't be used. A lot of opinions disagree with that. So if patients on chronic Nsaids, you don't discontinue the Nsaids because they may have COVID pneumonia. And if there's a clear indication for Nsaids, you still give them. But obviously if you're treating something like fever, you'd want to use another fever reducer to avoid the use of Nsaids, so use Tylenol. Next slide. And then ACE inhibitors and ARBs, like we talked about previously. Again, if there's a clear indication to use an ACE inhibitor, you give it regardless of COVID status. You don't stop ACE inhibitors because of COVID, and you don't start ARBs to prevent or to decrease the severity of COVID. There's no evidence for any of those three. Next slide. All right, so
there were just a couple quick questions before we move on to the next topic. I don't know if you could see the chat, Dr. Iskander. So from Taylor, so would you initiate antibiotics immediately based on chest X-ray and trend procal or trend?
Yeah. So exactly. So that was especially important in the initial part of this outbreak when we didn't have fast turnaround of COVID results. So there'd be a COVID pending. You'd have chest X-ray findings and fever. And in that case, definitely you need to cover for bacterial pneumonia until you get a COVID positive test back, or you can prove that the procal is not moving. But in general, yes, even if there's a COVID positive swab, I start antibiotics for the first 24 to 48 hours, trend the procal, and then look at the cultures. If nothing came up, just stop them. I think they're, thinking clinically, the benefit of antibiotics in treating pneumonia outweigh the risk of giving the antibiotics. So if you keep them on for 24 or 48 hours until you definitively prove there's no bacterial component, I think it's better for patient safety. But again, that's my opinion, and that was my protocol. That's just my advice from what I've done. And we did have several cases of people that, came in with a procal of 0.5, and then over several days they went to a procal of 2. So they definitely had a bacterial thing going on. Had we held antibiotics, they'd be significantly clinically worse. So yeah, that's what I was saying on that. Any other questions?
Or any additions from the other fellows or Dr. Prosper? Okay.
Okay, next slide. All right, so just like we spoke about, one of the experimental therapies. Actually, you know what? Let's open this to the floor a little bit. So, what have you guys heard about experimental treatments? We talked about remdesivir. What else have you guys heard?
This is Shirley. Our president had recommended some unique approaches.
Mm-hmm.
Sorry, I couldn't resist.
What were the approaches that you heard about?
Well, the president of the United States in terms.
Oh yes, yeah, the hydroxychloroquine and azithromycin. Yeah.
Well, it got worse.
Yeah, did you talk about the bleach?
And the light therapy, yeah.
All right, so yeah, obviously that's a crazy thing. Apparently there's a spike in ED admissions now for people trying to inject bleach, which is completely nuts. But yeah, interesting suggestions from the president. Any other thoughts?
Convalescent plasma.
Convalescent plasma. So what have you guys heard about convalescent plasma?
Sorry.
What was that, Dr. Prosper?
Well, just a quick comment that when you're in a position of leadership or authority and influence, it's good to be mindful of what you say and the recommendations that you give, because
Absolutely.
Many individuals who are easily influenced will take your advice to heart because of knowledge.
And that goes as physicians as well.
Right. So Steve, you said convalescent plasma?
Yes.
What did you hear about convalescent plasma?
I heard some, people who have antibodies, they can donate their blood, and the plasma can be used to treat patients who are critical. I've heard in some, cases it benefits, but they're obviously not randomized control trials, so it's hard to decipher exactly.
And there
what
actually
to take
isn't
from that
any
treatment.
randomized controlled trials, which we'll talk about. There, all of it's exactly what you're saying. They're all case reports and case series.
Case reports, yeah, exactly.
Any other things anyone heard about? I think someone said tocilizumab before. So what has everyone heard about tocilizumab, or whoever said that initially? All right, fair enough. So let's
there's a the BCG vaccine being protective also.
Yeah, I heard about that. I didn't actually include that. What was the thought? Was like basically you give BCG and sort of stimulate the immune system to fight the virus, right?
I think that's a trial that's happening in Australia. But what I heard is that those of us that did receive the BCG vaccine somehow, even if we do come down with COVID, seem to recover better or more.
I see.
Yeah.
That's a cool one. All right, so let's start with, I'm just going to start about basically the ones that we have access to. And, there's so many like the BCG vaccine and all these other, I think there's like 35 experimental trials going on. So I'm just going to discuss the ones we have access to. So the first one is remdesivir. We sort of discussed it previously. It's a nucleotide analog. So it sort of like inserts itself in the viral genome replication and stops the replication, effectively killing the virus. So there's a number of randomized trials going on, including I was informed here at Downstate. Usually in these trials, the exclusion criteria is transaminitis, ALT greater than 5 times the upper limit, or CKD, pregnancy or breastfeeding. And then, so just like a lot of these, efficacy was described in a case series. One specific example had 53 patients with severe COVID, hypoxia. They basically got compassionate use remdesivir for 10 days. And then they were followed at a median of 18 days. So 68% clinical improvement, 13% died. And then of the 30 patients who were actually intubated, 17 were extubated. 3 out of the 4 patients at ECMO were taken off, which is actually like, looking at that case series, it kind of seems like it's a miracle drug. But if you look at a lot of these unpublished reports, it's not as effective as these initial or like relatively recent promising studies are. I think a lot of these medications, like there was a race to like use them because of like these sort of like very small case series, and then they did like more systematic studies and found that the benefit was very minor, if not non-existent. So just moving on, next slide. And we talked about this. So I haven't personally used remdesivir, but I'm hearing a lot of these cases where there's some improvement. All right, so next one, this is a fan favorite, hydroxychloroquine and chloroquine. What have people heard about this? This is an interesting one. It was a very popular one, again, because of the president. So I don't know, what have people heard?
I'll just chime in. I've heard that there's cardiac toxicity with high dose of hydrochloroquine.
Yeah, I mean, even at regular doses that we give for this, there is cardiac toxicity, specifically prolongation of the QTC, and also cardiomyopathy. What else?
When you pair with azithromycin, that further exacerbates the QT interval, exactly.
Right. What else have we heard?
And there's also an issue of equity, because people that need that medication cannot get it with the demand for this use.
And that was a serious, that is a very, and is continuing to be a very serious concern. Pretty much every pharmacy on discharge did not have hydroxychloroquine. The recommendation actually was to just give it in the hospital and stop it to prevent the shortage, but like just the widespread use itself and like the, unfortunately the physician self-prescribing like really depleted the supply, and people with like long-term lupus controlled with hydroxychloroquine ended up relapsing because of the shortage. Anything else? Anything else anyone heard?
There are several trials, some of them in outpatient, in mild cases, and some of them in severe cases. Apparently, the severe cases trials showed that there's no improvement. The one in mild and mild cases did not show results yet, but it is possible based on the physiopathology and the way that the drug function that it will show more benefit in the outpatient cases and in the mild cases of viral infection.
All right, very good, yeah. So yeah, exactly. So this is a very controversial medication. A lot of, just like Laura said, there's studies that show efficacy in mild cases, like essentially cases not requiring supplemental oxygen, but in more severe cases, it shows. So let me just preface this. So the initial data for this was that it cleared the virus more quickly, and then there was some data from China that showed symptomatic improvement. Subsequent studies essentially showed that, just like Laura said, it was effective in mild cases, but in very severe advanced cases, it was at a minimum not effective. And then there's a new study, like a VA study that's coming out, that say it's actually could be harmful to use, given like the cardiac and the cardiac consequences and other side effects.
May I comment?
Yeah.
So hydroxychloroquine, its mechanism of action is to inhibit viral entry and replication. So some are believing that it's to be used early on in the disease course. It would not be beneficial when the patient's already hypoxic and ventilated, but in a way similar to Tamiflu, it would only be beneficial early on, and some studies are going on in regards to that.
I'm doing a presentation. Sorry about that. sorry, I'm at nursing station 42, so sorry for the interruption. Yeah, exactly. So, right, and I think that there was a huge rush to use this medication without sort of thinking of like the possible like consequences. But it made sense initially, and what you're saying is right. Like it makes sense to work initially, not if you have developed like a vasculitis or ARDS type picture. So just quickly, just go over it. The protocol we used here at Downstate, we gave 400 milligrams BID once, and then 200 milligrams BID for 5 days. Just next slide. So just based on my own observation, I exactly agree with Steve and these more recent studies. Use in advanced diseases is at a minimum, it's useless. At at a worst case scenario, it actually exposes these patients to untoward side effects. And that VA study actually showed an increase in mortality with use. So with use with azithromycin. Okay.
Excuse me, Yelena Ilyasova had a comment about the use of zinc. I don't know if Dr. Reinhardt, you saw her comment on the chat.
So
I was trying to unmute myself and I advanced the slides dramatically.
Yeah, I apologize.
That's okay. I hadn't seen it. Thank you. I don't know if you have any comments.
Using zinc with Plaquenil, if she could comment on it, I know she's on the call.
Sure. Yeah.
Thank you. Yelena?
Do you hear me?
Yes.
We hear you now.
Okay, sorry about. There was a doctor in upstate New York who actually tried the combination of Zithromax, Plaquenil, and zinc on his patients. He's a primary care doctor, I think, and he said he actually used it as higher doses than what we're using. He recommended Zithromax 500 once a day for 5 days, and the Plaquenil 600 twice a day, and then the rest of the days it was 200 twice a day for I think 14 days it was, and he did zinc supplement. And I'll tell you honestly, I did the same regimen for my both my parents had COVID and my uncles, and my uncle has really bad COPD. He was really short of breath, and what I actually noticed, the earlier when they started the symptoms, like right away when they had fever, I had them start the Zithromax and the Plaquenil. And I'm not going to tell you how I got the medication, but I got it. But I also, the zinc really goes a long way. The way that the doctor said it is that zinc goes into the Plaquenil is used with zinc because it allows the zinc to enter the cells and kill the virus.
Yeah.
And but what I noticed helped my family was that I ordered a steamer for them because I was giving them albuterol because they were very short of breath. Both my dad and my two uncles, because one has autoimmune disorder and the other one has just COPD, really bad COPD. Both uncles are smokers. But what I noticed helped them, the albuterol didn't do anything for them. But what helped them was a steamer. It was like I got a Mavis steamer on Amazon. And that steam, when they used it, they actually helped with the cough because they had a really bad dry cough and their O2 sat was going to 80s. So they actually prevented from going to the hospital, and they got better. So I don't know if that's something that you want to look at, because it's.
So that's an interesting. I mean, actually, what you're saying about underlying lung disease is interesting. I think I actually found that people with underlying lung disease actually kind of did better, and I think that part of the reason is they're able to tolerate like significantly less hypoxia. Like they're able to tolerate, for example, O2 sats in the 80s and 70s, whereas like a younger, healthier person would become extremely tachypnic in the same situation.
Okay.
And in terms of the use of, I've used zinc, in conjunction with Plaquenil. I still stand by the statement. I think that like you said, if you use it early on in the disease, it's helpful. If you use it later on, there's really nothing that, other than what we'll talk about later, that really slows the progression. The way I look at these patients is they come into the unit sort of like at a tipping point.
Yeah.
It's either they're going to improve or they're going to rapidly deteriorate, right? And whatever you can do that early phase, which I'll talk like what I did later on, but whatever you can do that early phase really changes the course of the disease. And that's what I believe.
Yeah.
So anyways, yeah, interesting.
Yeah, I think I've heard of this doctor too. He's supposed to release his results, but it's hard for us to make a recommendation on something. It's not a randomized controlled trial.
Right.
So, it's difficult to make a specific recommendation. Not that it doesn't work or not, but it's not something we can necessarily hang our hat on.
Yeah. And I use zinc on people. I use vitamin C, all that stuff. I think it's harmless. And I think that worst case, like it's harmless. Best case, there actually is benefit. So like definitely, that's something that should probably be looked into a little bit more. So anyways, moving on. So convalescent plasma, we've all talked about it. This is a very old treatment. We use this all the way back since the Spanish flu. And the theory behind this is essentially that you take plasma from a survivor, you take out all the cellular components of the mixture, and you basically give someone their plasma, which contains all of their antibodies. Data for this is very, very scant. It was, the only real data I could find is a case series that used convalescent plasma in 5 patients. And miraculously, all of them were taken off mechanical ventilation, which definitely can't be like a true reflection of the population, but it's encouraging. And downstate is a center too. That's an experimental center for the use of convalescent plasma. There's actually widespread testing going on, and if you test positive for antibodies, I encourage anybody that can donate to donate. The data is encouraging. Theoretically, it seems to be encouraging, and you could save lives by donating. So, yeah. Next slide. Yeah. So finally, tocilizumab. This is another, almost no data. And this is an Interleukin-6 inhibitor. So just like Steve sort of mentioned, there's a cytokine storm that occurs, and that's thought to do a lot of the damage to the lungs. By inhibiting different components of, the immune response, interleukin-6, tumor necrosis factor, theoretically, you should improve outcomes. And I've heard a lot of like relatively good case reports from across the street. They've been using it widely, and there's several published case reports. So again, these trials, these studies, if there's any data, it's as good as like having a systematic trial, especially in a crisis. So anything we can get our hands on that could help, we should implement.
We're using it a lot at the VA as well, in any patient that has elevated IL-6 levels.
Yeah, we don't have access to it, I don't think, on this set of streets, but they're using it pretty widely at Kings County.
Mm-hmm.
So next slide. So steroids. So this is one of the great debates, right? Is do we give steroids? Do we not give steroids? And the recommendations are very not great. So the IDSA recommends against the use of steroids routinely in patients with COVID. Society of Critical Care Medicine says if they have COVID and they have ARDS, give them steroids. Expert opinion says if they're intubated, they have ARDS, whether it's moderate, whether it's severe, give steroids. So this calls into question is, of exactly what we just talked about. When is the optimal time to intervene, right? I disagree with the IDSA. I gave steroids widely on our unit, partially due to lack of other modalities, and I've seen people very rapidly turn around, especially if the intervention is done early and not when they're like about to get intubated. I found actually that if they're on BiPAP, if they're in extreme amount of respiratory distress, steroids are essentially useless. You have to use them early, and you have to be aggressive early. And I've seen people that were on the verge of, very, very, like they come into the unit, they're on 25 liters, and then you transition the nasal cannula. You started right when they get on the unit, and they improve quickly over 3 to 4 days. So I don't agree with the IDSA. This is my opinion. Again, don't take this, literally. Don't use it if you don't want to. But I do believe that steroids are extremely effective, especially if they're used early in the disease. And if possible, it would be great to do a retrospective study on this hospital, look at the use of steroids. And there's actually some scant data from China, really poorly done study that basically showed that steroids do improve mortality in patients with COVID. That's very scant. It would be really good to do a widespread study. But in my opinion, if it's a life or death decision, I gave steroids and I've had good results with steroids. So you guys can use that as you wish. Next slide. So exactly what I said. Early use, aggressive use, in my opinion, and from what I've seen, maybe the 200 or 250 patients I've seen throughout this crisis, the results were pretty phenomenal. And I believe that we prevented a significant amount of intubations. Actually, there's internal data at Downstate. We started really using steroids here on NS42, and then that sort of spread around the whole hospital. When the hospital started using early aggressive steroids, the mortality significantly increased. But again, that's internal data. That's not systematic, but that's just, for you, if you get called into a crisis, consider it, and obviously use your judgment as you wish. Okay, that's it for me. Is there any questions on management?
Yes, I have one question, if I may ask.
Sure. Mm-hmm.
The concern, and again, I apologize, I joined your presentations later. Did you already address the concern for the younger adults and the blood clotting? That is,
yeah, we did. So the protocol that we're currently implementing. So in our unit, and the recommendation is everybody gets CBD prophylaxis, everybody gets Lovenox or heparin, regardless, unless they're bleeding for some reason. But if there's no contraindication, everybody gets CBD prophylaxis. If there's a very elevated D dimer, so usually 3 to 5 times the upper limit of normal, we do full treatment dose anticoagulation. So that's either with heparin drip or with weight-based Lovenox. That's if that answers your questions.
And there's
that's not only in young adults. That's in everybody. That's in older adults, younger adults. It doesn't matter.
Yeah, the concern for that stroke occurring for the 30 and 40-year-olds that are beginning.
Oh, yeah, she's saying there's case reports. Yeah.
I see. So you're talking about specifically the stroke. So that's an interesting phenomenon, and I think it's a phenomenon we don't know very well. But you're right. It does cause. It's being found to cause strokes in younger people. It's also being found to cause like very severe renal disease that we don't know how to treat.
I think it relates to the vascular inflammation and the virus binding to those ACE2 receptors and causing the endotheliitis. And
something more interesting about that, though. Just one thing. So you're right. Like there's definitely a vasculitis, but they did LPs on these people with encephalitis and like neurological manifestations of COVID. The virus wasn't actually in the CSF. Interestingly.
Yeah, because on this
phospholipid disorder. Oh, I'm so sorry.
No, go, Yelena. I was going to.
So sorry. It's just that I read something about phospholipid disorder, that it's causing antiphospholipid disorder, and they're checking the beta. I know you guys are. The thing is, what I'm confused about is that, well, I don't know. In our clinic, I do stroke clinic, and we usually you check the beta glycoprotein, like the beta glycoproteins, and you check the like the proteins for that. But the thing is that usually even if the first test come back positive, you still got to check it after.
Correct. That's not how you diagnose antiphospholipid syndrome.
And that's the thing. It's
because it can be elevated with various inflammatory.
Exactly. So
I don't think that's necessarily the mechanism.
No, it's not. But definitely. But that's the thing. Like so COVID is definitely prothrombotic. We know that for sure, right? But is it a direct effect of the virus causing a stroke, or is it the systemic effect of the virus? My belief is it's a systemic effect of the virus, not direct viral damage that's on the endothelial cells that's causing the damage. That's my belief. Because also, like, if you think about it, like, it will be very odd if the virus could like cross the blood-brain barrier and cause like direct damage to the brain, right? I don't know. It's just odd.
Yeah, because one of the major things bringing a lot of this forward too was the Nick Cordero, the Broadway actor who had his right leg amputated as a result of a clot. So that seemed to precede then some comments from, I guess, Mount Sinai Hospital with the physician there seeing those 30 and 40-year-olds. So.
Yeah, I don't know, Steve or Laura, you want anything else to add?
Dr. Kiwala?
Yes.
Can you hear me?
Yeah.
Thank you.
This is Dr. Theo. Can you hear me, Dr. Kiwala?
Hey, Dr. Theo.
Yes. I wanted to ask you, I heard your comment about intubation as part of intervention to treat the COVID-19. I really share your opinion about that, but also one aspect is the sedation. And sometimes deep sedation linked with the intubation. What do you think of that? Do you think that's necessary on all time? Because most of the time the patients get sedated.
Yeah. So, I mean, if somebody's intubated, in most cases, unless they're severely like vegetative or obtunded, they're going to need sedation, because if you don't sedate somebody on a ventilator, they're going to like pretty much fight the vent. And if they get agitated, they're not going to oxygenate well. So you usually have to sedate, but you don't want to over sedate. You want to sedate them to something called a RASS of -2, where you can still wake them up, but they're, comfortably sleeping, not fighting the ventilator. I don't know if that answers your question.
Yes, my question was answered, because they have seen that patient deeply sedated, and then when they try to wean them off the vent, it is a challenge. But thank you.
Oh, for sure,
you
yeah.
answered my question.
No, you don't want to. You
That's
definitely
why you do
don't
sedation
want to
holidays.
Yeah. You always want to do like you don't want to do anesthetic level sedation where they're completely out of it. They don't move. Like the level of sedation you look for is like you can shake them, they open their eyes, they can look at you, and you always want to give sedation holidays. You don't want to keep sedating someone. You want to, for 30 minutes, hour, as much as they can tolerate a day, you take them off sedation, they open their eyes, they look around, so definitely you don't want to overuse it, but you don't want to underuse it either, because if you underuse it, then you basically defeats the purpose of intubating.
Thank you.
And we had one more question from the chat from Shirley.
Yes.
Go ahead, Shirley.
Since a lot of the people on the call are involved in primary care, particularly of older adults, I have heard some primary care providers, I won't tell you from where, on a COVID-19 call, talk about the fact that people with allergies and asthma should not be using inhaled steroids, either nasal.
No, that's absolutely, even the IDSA disagrees with that. So you should, like, the IDSA says you shouldn't give inhaled steroids for COVID, but if they need steroids, they absolutely should be getting steroids.
They're using it for asthma,
inhaled
they
or
should
systemic.
continue it, yeah.
Yeah, inhaled or systemic, it doesn't matter.
It was interesting because I looked it up after I heard that, and then I happen to have asthma, so I called my pulmonologist and to make sure that I.
No, that's,
yeah, there's no evidence for that.
Primary care doctors doing that, they should be told like otherwise. That's actually like very detrimental to the patient. To stop.
I will try to get that message to those people.
Yeah.
Listen to your pulmonologist.
Yeah.
Yeah.
And I think this brings us back to the point, and I want to reiterate, it was said earlier before, but the point is that we practice evidence-based medicine, and it's very important to go where the evidence is, the standard of care. Something has to support the decisions that we're making, okay?
Absolutely. And until those randomized control trials come out, it's hard to make a definitive recommendation. Only experimental treatments and treatments that are undergoing a clinical trial at this time.
Right. Exactly. And the ideal way, like obviously in an emergency situation, you do whatever you can to save a life. But ideally, if you have time, if you're prepared, you want to enroll these people in as many clinical trials as you can. That's the proper like evidence-based way of doing things. But obviously, like, if you're getting inundated with very sick patients, you're going to do whatever you think is going to help. And hopefully, someone looks at that data retrospectively and comes up with an answer to our question, Any other questions for management?
think that's why these sorts of forums are very important at this time, so that we can review the current available evidence, discuss things that are circulating in the community, and move back towards a more evidence-based practice when people have been deviating, as in Shirley's question.
I have a question. Hi, this is Maritza. I have a question for the doctor. I am in outpatient dialysis, and I know that you did inpatient, but I have patients here in the dialysis center that we are not treating at all. We're not giving them anything for COVID. And I have 16 patients right now. And we are doing testing to see if they become negative. And of course, a lot of them are not becoming negative because we are not treating it. So my question to you is, how long should we wait in order for us to retest the patients? Because, for example,
I wish I had an answer for you. I asked the same question myself. I've had people that test negative after like 4 days, and I have people that stay positive for weeks. I think part of it has to do with the patient's age, the patient's inherent immune status. I think all of those things play a role. And you know, patients that are dialysis bound do have an innate immune dysfunction. So I don't know. I really don't know. And that's another, it's also, you know, it's very good that your center's taking COVID positive patients, but a lot of these dialysis centers are rejecting these patients because of COVID status, which is completely crazy. So I don't know. I wish I had an answer for you. It affects everything. It affects getting dialysis center. It affects disposition. It affects whether they can get a home health aid, but I'm sure they're going to talk about that later.
Thank you.
But yeah, good question. I don't know.
Okay, so we're going to, if there's no other questions, we're going to move on to Dr. Yancey, who's going to talk about the pandemic's effects on mental health in older adults.
Can I ask another quick question to Dr. Q. Wallace?
Sure.
Sure, Theo.
Okay, yeah, it's me, Theo. In your presentation in the treatment area, you actually had a fairly nice development about the hydroxychloroquine. What about azithromycin?
Yeah.
What about azithromycin?
Yeah,
how does
hydroxychloroquine and azithromycin
in that scenario?
Yeah, so there was one study that showed like a enhanced improvement in symptoms when you add azithromycin. For whatever reason, in downstate, we're a center that was mandated to test whether hydroxychloroquine plus azithromycin causes an improvement. But in general, you just use hydroxychloroquine. The addition of azithromycin is purely like a theoretical study based on a previously like poorly done study. The actual risk of putting the two together, I don't think has like outweighs the potential benefit you could give anybody. There's a very high risk of prolongation of the QTC and like possible arrhythmia. I would and actually like even like the IDSA and other people do not recommend that combination. So if you're going to give something, give hydroxychloroquine. If you're in a clinical trial for hydroxychloroquine and azithromycin, they should be inpatient. I would never discharge somebody on hydroxychloroquine and azithromycin. That's my answer to that question. I don't know if it answers it.
All right, thank you.
No worries.
Okay, Dr. Yancey, are you with us?
I'm here. Thanks, Dr. Reinhardt. I hope everybody can hear me.
I can hear you just fine.
Good. I will assume that everybody else can. Thanks for having me. I'm also mindful of our time. I have maybe 8 or 9 slides to go over, and what I want to talk about is how this pandemic, how COVID-19 is having an effect on mental health in our older adult population. So, as we kind of already know, one of the defining features of COVID-19 is predilection for infection of our older adults. It's deals with a chronic health condition, so it's very intuitive that COVID-19 is sort of going to disproportionately affect this population. And what I want to go over is just, as you can kind of see here with the goals and objectives, you know, where are we right now in terms of what we know, what have we learned before, and use that knowledge to sort of extrapolate what are the effects of COVID-19 on mental health in general. What does the initial data even say? And why is it going to be so bad for our older adult population in terms of mental health issues? And kind of going from there, try to weave in doses that we've already seen, since, you know, kind of unfortunately, we all are on this front line together, and go over some of the interventions and kind of wrap up there with seeing where things are going to go in terms of the future. Next slide, please. So the current state of information and research is, as you can already see from this slide here, not great. We don't know a whole lot. So we're at least starting from a standpoint of Socratic wisdom. We don't know a whole lot about what's going on. And the data, you know, I think this slide is a kind of a good segue from Dr. Iskander's discussion of management, is that we don't know what works. We don't know what's going to happen. And that's especially true for the mental health field. So you can see, you know, the Lancet, a call for action, from the American Journal of Geriatric Psychiatry. You know, we need knowledge. We need more data, because we don't know a whole lot about, you know, what are the individual and psychological factors. We don't know a whole lot about what are the social and population factors. You know, how is this all going to tie together? And I just add that third point there on neuroscience and the effects of the virus on the brain, because for the most of the rest of this presentation, I won't touch on those factors, but this is something else that we don't know a whole lot about. We can kind of extrapolate a little bit. We know that from a 2005 review that about half of zoonotic virus epidemics have been caused by nootropic viruses that invade the CNS. So it is possible that COVID-19 is going to have these direct neurotoxic effects and some kind of long-term repercussions or ramifications. For instance, the Spanish flu epidemic of 1918 to 19 was correlated with a spike in post-encephalitic Parkinsonism. It's quite common that post-infectious fatigue and depressive syndromes have been associated with other epidemics, and it seems very possible that it'll be the same will be true of this as well. Next slide, please. So you can see from this rather alarming graphic image of a man looking at a Newsweek cover of that a lot of what we know is from past epidemics, past pandemics. What we've learned from SARS, just brief, there are some alarming numbers that have come out of studies especially from Hong Kong. It's associated with a 30% in suicide in those aged 65 and older. Recovered patients remained dead, and 29% of healthcare workers experienced what was considered probable emotional distress. So I think it's reasonable to expect increases in PTSD, stress, and psychological distress in both our patients and us. The lessons that we can draw from other disaster psychiatry lessons. Some of them can be large-scale disasters like the World Trade Center or even Deepwater Horizon. And these seem to almost always be accompanied by increases in depression, PTSD, substance use disorders, and just a whole broad range of other mental and behavioral disorders, not excluding things such as domestic violence, child abuse, and probably most relevant, elder abuse. Just a few numbers that kind of strike closer to home for New York in particular. After the 9/11 attacks, 1 out of 10 adults in New York signs of major depressive disorder in the 1 month following the attack. Not only that, but 5% of New Yorkers reported increased alcohol use after attacks. So you can see from that diagram in the right hand that, this is horrendously outdated material at this point, but the comparability of this disaster and this to SARS is, other sort of disaster lessons, the comparability there may be somewhat limited. So we're kind of working on thin ice here, not a whole lot of information to go on. Next slide, please. Okay, but we can certainly use some data that we have, a lot of it is just polling data to kind of speculate that this is going to be a big deal. I won't go into the sort of details of the polls that are collected here, but I think the bottom line is that people are very anxious. They're anxious about the possibility of getting coronavirus. They are anxious about becoming seriously ill or dying from coronavirus. But even more so than that, more people are afraid that their friends, their colleagues, their family are going to get COVID-19. I think it was an interesting point that Express Scripts recently released a little bit of data from their own numbers that said the number of weekly prescriptions for antidepressants, anti-anxiety medications, and anti-insomnia medications jumped up 21% between February 15th and March 15th, when the WHO declared COVID-19 an actual pandemic. Okay, next slide, please. But I think, you know, far more relevant to this forum, to this venue, is understanding exactly how this is all going to play out in our older adults. We know that medically speaking, this population's at high risk, but there are a whole list here that you can already see up on the slide that kind of adds to what we anticipate. I think what a lot of us are already seeing, no matter what role we play in this pandemic and treating patients. So we're seeing a lot of these things already. So I'll go through some of this list here. People with pre-existing or underlying mental health conditions are simply very high risk for having these things exacerbated, whether it's anxiety, like I already mentioned, or depression. We work with a population that already has a worsened sense of physical health, pain, and disability. And this is, very interlinked and interlocked with, a sense of identity. And this is going to be a very stressful time in terms of that. I mentioned grieving here because a lot of our older adults will have losses around them. It's going to lead to grief and bereavement, or simply even just frank depression. I think it's pretty intuitive to understand that a lot of our older adults are going to have disrupted routines, which goes hand in hand with some of the other points there. The loss of the traditional care structure that we have in place. Our clinics are closed physically, memory centers, daycare centers, senior centers, all of these places that traditionally help put together some literal, real physical structure around our patients to help them are now closed. And it's very possible that some of these places may never, which leads a lot to caregiver stress, because all of a sudden we have the traditional physical structure that helps hold our patients together. Our caregivers are now taking a lot of that burden, which of course is going to naturally lead to their own isolation, their own anxiety, and possible burnout and stress as well. I'll make a special note of caring for our patients with Alzheimer's disease and related dementias, and saying that this population, this subsection of the population within our population of older adults, is even at higher risk. They may simply be unable to follow the recommendations from public health authorities. Whether it's due to apathy or depression, or those with severe dementias who may not even be able to understand, they might not be able to appreciate or even remember what the recommendations are. And a lot of our non-pharmacologic interventions in general for those patients that we have with Alzheimer's disease and other dementias involve social and physical contact, social groups, exercise groups, all sorts of different types of therapy. And now that's sort of all been upended. Next slide, please. So this really is sort of a perfect storm of issues for our older adults. And I think a lot of what we've talked about already is this aspect of social isolation and loneliness. And it's been such an issue over the last few years that the National Academies of Sciences, Engineering, and Medicine put together this report, which came out in very timely fashion. It came out this February. And I think we already know that there's very significant risk associated with loneliness, with social isolation. You know, there are higher rates of heart disease and stroke. There's a 50% increased risk of dementia. And that a lot of people living in our community are considered socially isolated. And what I often find myself telling patients now is that despite these recommendations to socially distance themselves, it certainly does not mean social isolation, but it's a huge problem. These are patients who, by virtue of either retirements or inaccessibility in terms of their mobility, their hearing and vision loss, their cognitive or physical problems, those are already ways by which our patients are disconnected from the world. And this is just yet another barrier. I will point out that, you know, the elderly as a group are very diverse. I think there is some reason to think that a lot of our patients with some access to resources will likely leave the crisis either in better shape or in sort of neutral shape. But, you know, as my third point there on the slide kind of suggests, that the health disparities that we already know exist, they're already out there and affect all of our patients, they will just simply become more obvious, whether it's a breakdown along ethnic lines, gender, class, immigrant status. All of these things, you know, we're already seeing it. This is anecdotal, but we already see how it breaks down for our patient population, for instance. Next slide, please. So I just wanted to go over some of the interventions, some of the resources that are out there that are just starting to get written. The APA, I placed that link there for a reason, is that there's a very long list of webinars, resources, and, you know, despite the URL saying psychiatrist there, it's really intended for a more general audience, for general practitioners, for hospitalists, for anybody working with patients at this time. How do we care and how do we provide some aspect of support for our patients at this time? So I'll leave that there, but I'll talk a little bit about like what has actually been done. So obviously there's been a much bigger movement to telehealth. But I think this ties into a lot of what we've seen before, that there is, you know, this so-called digital divide, often with our older adults. There was a poll that was done that said about 1/3 of Americans over 65 were not at all confident about using digital technology, and that half of them needed help in setting up new devices. You know, I will say, once again, sort of anecdotally, that I think that number is much, much higher with our patient population, let alone access to something like a broadband connection, which if you've ever tried to video chat somebody without good internet, it's just a subpar experience. So I guess on that note, there is some research that's out there on telehealth, and I think there's going to be a lot more moving forward. I saw one in particular that I thought was interesting, especially for this group of patients. It came out of South Australia, and they compared telehealth versus home delivery of interventions in older adults with mild to moderate severity dementia, and they found that it was essentially non-inferior, which doesn't sound wonderful, but it is saying that we can still provide support. It's not, despite that sort of physical aspect going away, there is still ways that we can deliver very good health, deliver very good care, despite the physical limitations. And I think it requires some flexibility, requires some thinking to adapt to this new situation. And then I put here that I think on a sort of very simple level for all of us that provide care for patients, that just simply communicating regularly with the older adults that we're working with and in our lives and expressing some kind of support is that, I think that goes a lot further than what that sort of simplistic message suggests. Next slide, please. So initially I put this up. Those are the Chinese characters for crisis. And it's supposed to be danger plus opportunity, but I discovered later that that's kind of wrong. But I still think I still think that it's a pretty good way to view this situation. It's a good way to view a crisis, that despite the immense challenges and the obstacles that we're going to have, especially when it comes to mental health issues, that there is a silver lining. There's a lot of opportunity here for us to reach this older adult population. There might still be something to learn from this. With that, I will just leave it open for any questions or comments.
So as Dr. Reinhardt, I have just one, I think, overarching comment is, as we move, hopefully, through the acute phase of this pandemic, I think all of us, primary care, mental health care specialists, have to be prepared, as you've intimated, for the long-term effects of this terrible pandemic on all of our mental health. We're not talking much today about healthcare workers, but our own mental health care as well, and our own mental health status. There is a whole world of stress out there, and we are going to be facing a whole population of people that need our help, and mental health care, specialty mental health care, is in very short supply in the United States. So there will be, I think, a second mental health pandemic after the COVID-19 pandemic wraps up, and we have to be prepared to work together as a team to handle that. So I'm looking forward to keeping this conversation alive with all of you as we move on to find solutions to what's to come. Any other comments or questions?
Yeah, I just want to add to that, Michael. This is Shirley. There are certainly going to be some big challenges with the cutbacks that are going to happen in healthcare and money for healthcare. We know at the university we're going to have to be cutting back. Where that will come from is hard to tell at this point, and cutting back on a place that was struggling in the first place. And the policy implications of all of this for health and healthcare of all kinds is tremendous. And certainly we know historically that when we start to cut back, we start cutting back on the things that some of the most vulnerable populations really need, and mental health services have always been pretty vulnerable, as are some of the other softer services we have in our society. So there are policy implications for all of us who care both about older adults and these kinds of issues to really pay attention. It's going to be very trying, and I think the economic situation is going to add to it 1,000-fold. On that happy note.
Any other questions or comments?
Yeah, one quick thing. Like I don't know if you guys have noticed this or not, but do you think that there are direct psychiatric effects of the virus? Do you think that there will be like other than the impact, the social impact? Do you think that the virus can exacerbate underlying mental health conditions, or have you heard of like case reports of that happening?
I've heard that folks who've been basically on the ventilators for a very long time are coming out somewhat cognitively challenged.
Yeah.
So it's not so much in terms of underlying sort of mental health, sort of like psychoses or something like that, but that sort of cognitive function is really challenged, that something is happening. There's a lot that we don't know. Obviously for those, we're all going to need like serious post-traumatic stress like therapy, all of us.
Right.
But it's unclear in terms of it signaling or doing something else in terms of underlying mental health issues. But I haven't heard anything other than cognitive changes as a result of being intubated and under the ventilation too long.
Thank you.
So I don't know if we have that data in the elderly population yet. I think, unfortunately, many of the patients that we're treating in our service that have become positive with coronavirus have not done well, as they are at severe risk for complicated courses, poor outcomes. That has proven to be very true. And so I don't even have anecdotal knowledge to answer that question. We haven't had a large enough survivorship for me to make a judgment.
So actually, people, you've noticed, like, people with underlying psychiatric disorders have had worse mortality.
So again, you haven't rotated on our service yet, but predominantly we are treating in our clinic, about 80% of the folks in our clinic are people with Alzheimer's disease and related dementias with associated neuropsychiatric symptom profiles. But on the flip side, and the other 20% of our population is also not faring well. And I don't want to make this very gloomy, but we have not had great outcomes for some of our patients.
That's horrible.
It has been horrible. So I guess we're hoping to learn more as time goes by, and the geriatric psychiatry community is rallying and organizing to collect data and to see what the direct neurologic ramifications of the virus are, whether there are any, but I don't think we know yet. I don't know, Dr. Yancey, if you found anything in your review, or Dr. Cohen, I think you were on earlier.
I mostly saw neurological consequences, like dizziness and stuff like that. I will say that anecdotally, I felt that there have been patients that we've seen over the past month that were tested COVID-19 positive or were suspected to be so and fared worse in terms of some of their neuropsychiatric symptoms.
Yeah, because I've noticed that too. Like, I've noticed that a lot of patients with underlying schizophrenia, are coming in fully catatonic with no history of catatonia, which is just interesting. Because neurology and psychiatry, I feel like, go hand in hand. And I mean, we don't know the pathophysiology of a lot of psychiatric illnesses fully, but I feel like if there's neurologic sequelae, it would be a logical extension to say that there would be psychiatric sequelae as a direct result of the virus. But that's just like what I've seen. I just was interested to see if you guys had any actual data. But yeah, interesting.
Yeah.
May I have a comment, Dr. Reinhardt?
Hi.
Dr. Theo?
Sure.
Yes, it will be quick. Personally, and based on data and what we're going through right now, I believe that only it will not be science. It will be only God and time that will be the real judges in regards to regaining confidence among providers and patients. Because if we look at it, probably in 3 months, 6 months, there will be many patients still scared to come and visit a provider because they will be scared about thinking the provider itself might be infected and vice versa. And on the other hand, I believe when we are about to treat patients, especially in our university system, we learn a lot about culture of safety. But right now, with what's going on, we see that the safety of cultures have been shaken, in the sense that in many communities, like our Caribbean community, African community, the worst fear, it's not the death itself. It is what they call the humiliation associated with it. In other words, when they cannot have family members to follow them, they cannot have friends to follow them. So it is really a big challenge. So we are praying God, and at the same time, we are praying like scientists, like Dr. Reinhardt, Dr. Cohen, Dr. Prosper, and all of you, and all the outstanding scientists will come with something, and very fast, so we can try to solve this problem. That was my comment. Thank you.
Okay, so let's move on. I appreciate that we're running up on the end of time. So I know people had taken time to prepare, and I'd like to give everybody a chance to speak. I'm hoping everyone doesn't mind staying on for a little bit longer for what I view to have been a very fruitful and information-rich presentation. Do we have Dr. Lawrence and
I'm
team?
here. Yes. So the next section is primary care. I am an adult health primary care nurse practitioner. The next slide, please. My office of my dreams. So I am presenting the
That's
impact.
what our clinic looks like.
That's what I said. I am presenting the effects of the impact of COVID-19 on our outpatient primary care practice and our community residents, not just patients, but our community residents. Next slide, please. So COVID-19 pandemic has changed, as a couple of the other presenters have said, how we view healthcare and how we deliver outpatient services. SUNY Downstate has been designated a COVID-19 only facility. And because of that, our service has moved to telehealth. So we are seeing our patients virtually. And that has created challenges of its own, from internet connections, just to, as I think Dr. Yancey says, because he's in our service right now, having patients connect that don't have enough Wi-Fi or bandwidth. So this is what we're up against right now and may become our new norm. And this is all in an effort to protect our patients, which is we are the geriatric psychiatry unit, and also to protect ourselves from contracting the virus. And we are offering preventative annual visits virtually. Okay. The number of visits, and on the whole anyway, to ambulatory services has been decreased. The article that I used stated it was 60%, but also the reason that has been increased, especially I'm going to use Downstate as an example, is that a lot of our outpatient primary care providers have been redeployed or reassigned to inpatient care to care for the COVID-19 infected patients or patients that have contracted COVID-19. And this has been seen as a 60% decrease in outpatient ambulatory care since between March and April, which is when in New York State, when the virus was at its peak, or still is at its peak. Dramatic declines in the number of visits observed in all regions of the US, but greatest in New England and the mid-Atlantic states. And as the number of in-person visits decreased, telehealth visits has increased as we expected. But the increase to telehealth visits only partially offset the decrease that happened in the outpatient clinics, because not a lot of services can actually transfer their service as we did to be in telehealth or virtual. 30% of visits to these ambulatory practices are now provided via telemedicine, and the decline in programs visits were more among surgical, well, as you expect, surgery, outpatient, primary care, OBGYN, oncology. These are services that cannot readily be transferred to telehealth. And the decline was more among school-age children and older adults as expected. Next slide, please.
I was just going to say that even with our best efforts to transition to telemedicine, the technological and tech savviness barriers to implementation have proven quite astronomical. I mean, I think even on our best day, we've gotten to about 60% of our normal visit rate, maybe 70%.
And others from our team, our social workers could chime in, this is our presentation. So we're the ones that's out there in the virtual trenches that have to somehow circumvent this and provide care for our patients as needed. The implementation of social or physical distance has been mandated in most states and in a lot of countries. And this is in an effort to reduce transmission of the virus, as we can imagine. Social distancing and sheltering in place to prevent decrease in transmission rates may also result in social isolation and loneliness among our patients and our community residents. Social isolation is around regardless of age. It's not only specific to the geriatric population or older adults, but it's at greater risk, especially now that social distancing has included not having your relatives or friends allowed to visit you in this long-term care facilities, the skilled nursing facilities, or assisted living. One of my patients that I had last week, her son was actually complaining to me because I did not realize until now that once the COVID-19 transmission is in the facility, the residents, to keep them safe that do not have it, are secluded or quarantined to their room, which is usually just a single room, one room that they're in 24/7. The staff, they're short-staffed, they're overworked. They don't even spend time to speak to these residents except to deliver food or meals or to give them medication. So her son, the patient I saw, he said that he's noticed his mother has lost some of the functions that she had before because he's trying to Skype with her or to connect with her over Zoom, and she could before, and now she's not remembering how to turn on the television, how to use the remote. So that's further isolating her because he cannot communicate with her. So next slide, please. So I think I'll skip these because we don't really have a lot of time. Next slide, please. So a lot of patients in the community have realized that their general provider, like Dr. Prosper has been telling us, have been redeployed to inpatient care, and they're not able to have their regular routine outpatient maintenance visits. So a lot of patients that usually come in to have their chronic conditions managed are now left sort of in the oasis or in the spot in between inpatient care and outpatient care because there's not a lot of outpatient care that's still around. These are health system and policies in an effort to manage and treat patients with the coronavirus have neglected or canceled outpatient wellness visits. Preventative screenings, preventive health, which was not always the highest priority for a lot of healthcare institutions, is now almost non-existent. Routine scheduled appointments and office visits to manage asthma, diabetes, and such are canceled or absent because a lot of our health system did not think how to maintain these cares along with caring for the crisis that came with coronavirus infections. Next slide, please.
Oh my.
You could skip that one. This is an actual quote from a patient. It said, "My appointments have been canceled and I have developed pulmonary arterial hypertension, ascites, anasarca, and pleural effusion, and my specialist appointments and tests have all been canceled too. I am really short of breath and with any exertion and cannot even get to the pulmonary function tests that are needed. It's a very scary time for me." So this is what our patients are facing out there. We're facing the challenge of not getting infected and caring for the onslaught of additional patients in the hospital, but our patients are out there scared to death that they are going to die because they cannot get their routine care. Anyone else seen this in their practice or have any comment about this?
I did have a quick comment though.
Yes.
About just generally speaking. Yeah, you guys can skip these slides. I just added them, but just skip them. You're doing a much better job than any of those slides. No, my question is, do you think that, like, given the, the pandemic and that the fact that a lot of people are being like essentially discharged to close follow-up, that a lot of the outpatient effort should be switched to transitional care as opposed to like, just like refilling medications and so on? Because I feel like a lot of these patients that are discharged, a big proportion like get readmitted or like they need close symptom monitoring. So do you think, like, as an institution, we should switch more of our efforts to transitional care as opposed to regular visits?
At this point, we probably should, and it's opportune that you mention that because our fantastic social workers are going to cover this in the next section.
All right, great, thank you.
All right, so we're very fortunate, one, that you're all sticking around after 5 so far. Thank you for that. And also that we have some very dedicated social work staff and an anthropologist, Dr. Taylor, that are going to talk about the social and cultural determinants of health during the pandemic. And I think that Margaret Salmieri you're still with us, right?
Yes, yes. So if you can take the next slide.
Sure.
Okay, thank you very much for staying with me. And my presentation will be narrowed to our community and my experiences being a social worker to COVID patients from the beginning of admission to this hospital. So before I start, all social workers start conversations with the patients from, did you eat today? And did you have a place to sleep? So those are a few numbers about the patient population 65 and older. We have here in this country 8.6 million people who are facing the threat of hunger. 13.8 million who live alone. That's a very significant number when it comes to our practice. 15 million people who have disability and 4.7 million who live in poverty. And as you know, 80% of US COVID deaths are people who are 65 and older. Now, next slide will tell us a little bit about our community. And then you will see that how disproportionately we have immigrant population. 51% is in Brooklyn, in Flatbush, compared to 38 in Brooklyn and 36 in New York. In terms of race and ethnicity, we have 77% of Black, with the high rates of hypertension, diabetes, ESRD, dementia, and also high risk for COVID. Next slide, please. So now, because I started from food, what is the food distribution for our patients? Many of our patients with low or middle income, we were encouraging them to go to adult day programs, because then they were able to get once a day a meal and take another meal quite often home. Adult day programs are designed for the people who have Medicaid, which means the income is lower than $800 per month. So this meal is very significant help. Senior centers are open to all people, makes no difference what their income would be, but they are really, most of the low income people are attracted to them, quite often for the same reason. They have a meal there and take meal home. With this epidemic, all those programs were closed within 4 hours. So there was no plan, like California had a specific plan for the emergency, and they would continue providing meals and living on a patient's doorstep. We didn't have this program. After some time, they changed this and they started delivering once or twice per week. So there are some websites how you can get deliveries for homebound patients, how you can get a neighbor who will bring this for free. All of this require really that the person will be computer savvy. Next step. And so now, because I am running, because I want everybody to have a chance to speak. What are the challenges for hospitalized elderly patients? Many, as I mentioned before, many of our patients are immigrants. And they live the immigrants' a dream, which means that they work very hard. They had jobs which they weren't paying too much, but they bought a house. They have a small social security. Their children moved out of the state, and they are doing well. Many of them are here in Brooklyn by themselves. And When the patient is hospitalized with COVID, all the agencies which, if the person had a home attendant, all those agencies require that there will be 14 days quarantine from the day of admission. Quite often, the patient is ready to be discharged just after a few days. So there is no possibility of restarting of these services unless somebody from the family can come forward and help this patient to care for this person. And if there is nobody, then we talk about a referral to rehab. Not everybody really meets criteria for a rehab. So the person is and we are in a difficult situation when there is like no one land. What can we do? The agencies had this policy across the board, just in a way of protecting the workers. Another issue which is also across the board, what happens if the person lives alone and the family lives in different state, and we have many patients in this situation, and this person needs a home oxygen. Somebody has to wait for the home delivery at home and sign and confirm delivery. But if the person lives alone and the only friend is a neighbor next door who is afraid to come, how this can be done? So there was a small but very important part of this discharge planning. So then it comes to the Medicare opposed to Medicaid. Medicaid covers all services, even 24/7 home attendant services, but Medicare only covers skilled nursing and then few hours of home health aid, which is always for a short time. It can be week, it can be 2 weeks. Quite often it's not enough because, like somebody mentioned before, there is a significant deconditioning during the hospitalization. Some patients are staying here for a much longer time. Then there was another issue because even with this Medicaid coverage, most of the agencies did not were not accepting COVID positive patients. And then the staff was calling sick. They didn't have enough coverage. So I know that psychiatrist was already talking about this emotional burden on patients, families, and caregivers, but it's so important that I felt that I would just reintroduce this. Can I have next slide? Okay, so then another challenges. For the patients who live alone and have this medical coverage, normally we would call the adult protective services to let them know that for them to come and provide some care. There were so many calls that you couldn't get to the main number 212, and you couldn't make this referral on the website because everything collapsed. So there was also lower number of reports of domestic violence because patients who were COVID positive, elderly, were afraid that they have no other options. So they had to really accept whatever was coming their way. Then there was another very important component. When you think that somebody who really fought this and is being discharged should be seen as like almost a winner, some of them fear that they will be blamed in the immigrant community for bringing the illness to them. So I heard just 2 days ago a patient who said, no, I don't want an ambulance. I don't want any neighbors to see that I am coming by ambulance. I don't want them to know that I was in the hospital. So, and then this epidemic, like all of the hospitalizations, they bring to the light all the problems which the family had prior to those admissions, because now they have to agree on some aspects of the patient's care, and sometimes it's difficult to really get this agreement. Can I have next one? Okay, so finally patient is at home, is discharged. We took care of all of this. So now, who will, if the patient lives alone, who will monitor patient health, the compliance with medication, Now, the other part is I know that New York Presbyterian Cornell has a special program which they introduced right after the start of epidemics, which was with pulse oximetry. All the patients who were living with oxygen also got a prescription. And for the next 2 weeks, nurse was calling them a few times a week, checking what are their results. And that is as a prevention of rehospitalization and also as a follow-up to this person of people health. And
I just want to say too that Kings County, they have a texting system where you basically have like a private text line with the patient, and it sends them reminders daily to tell them to basically tell you what their symptoms are.
Very
so
good. Very good.
It's an interesting thing, yeah.
Yeah. So that's very good. Then there is another question: is that should I rather stay at home and because it's expected that I will be sick, or should I call 911 because I feel worse? And if you live alone, who will be the one who will be calling this 911? Can I have the next slide? Okay, this is something which maybe not too many people think about when it comes to pandemic, but it's a very important part of our life journey, and has so many cultural, religious connotation to it. And then this so many people are faced with really cost and this very unusual situation with virus, from nowhere. So what happened? I called many funeral homes in New York asking for a cost of cremation and etc. The waiting time was for weeks. So you couldn't really get a burial within 1 week. Cost for those who were for cremation was $1,250. They weren't even taking referrals. Those which cost $45,000 or $6,000 that you could get this within 2 or 3 weeks. We had during this pandemic many patients who were not our patients prior to this admission, but it also applies to our patients. Many of those numbers in our charts were not updated. We did not have nobody to contact. We had number of times when on my service, when the couple was coming to the hospital and one of them died and another was still in the hospital, and there was nobody else, and the person has altered mental status. How to navigate all of this. Then some of our patients have a family living outside United States. They cannot afford bringing the body. They cannot afford cremation. There was nothing planned in the past. So what it always comes to, the same is with dementia, the same is with everything else, is importance of planning. So everything will be much easier when such a crisis will come. Because in the end, we should be able to respect this person's religious or cultural observances because that's the life worth it. Can I have next slide? Okay, and I want to bring to your attention, this is really sarcastic, naturally, what you were talking about this before, that not all seniors have computers, and even if they will be given computers, many of them cannot use them. I went to the patient a few days ago and I asked him, can you please, Mr. Smith, sign here? He said, I'm not signing. I said, why not? Because I don't know how to write. And people are coming from the countries when the access to education was not equal. Programs are built by the young people who are very familiar with technology, but not everybody is. So that I think should be taken into consideration building another crisis intervention. Can we have next slide? Okay, those are social community resources, and this will kind of reflect to the next one. Many people who live alone, they have a pet. This pet is the only friend they have. They will try not to come to the hospital or look for any type of help as long as they can, because they do not want to leave the pet alone. And I think that you know, we don't take this into consideration often enough. But there are services in the city which they will help this person to come to the hospital and the pet to be taken care of, or for the person to have the ease in cost of feeding the animals. And so there are different numbers. I want to just bring to your attention that hideside.org, which is available to everybody. And when you will open, you can buy the zip code, see what type of services you are looking for on your left side. If it's food stamps, you will have a food stamps, a pantry. There will be specific resources during the COVID-19. So we don't have to remember all of those numbers. It's enough if you would remember this hideside.org. Can I have next one? Okay, so those are my suggestions, that patients and families should be engaged in long-term planning with their providers. This should be one of the goals for every elderly person. I know that we check boxes, but that's maybe not enough. And the contact numbers should be updated on a regular basis. Older relatives may die, move to a nursing homes, or go back to their country of origin. This is part of being older. Better use of this oximetry, and then we should really familiarize families more with the Medicaid pool to offer the Medicaid coverage to more people, and talk openly about preparation for burial, because it can be a payment plan, and then it would not be you know, really such a burden. So I believe it's in the next slide, is my last slide. Okay, and that is my last slide. This is my second epidemic. So I learned some things from the AIDS epidemics. Healthcare proxy, you would not remember, but this is the time when it came from. A lot of housing benefits. There were so many people who put their efforts together, and now it becomes a part of the care. The same medical reserve team was built after 9/11. If we have to have a system to care for elderly, not like scattered, but some system when, if there is a need, we can reach out to them. So they would not be staying in a basement alone and hungry. Thank you. Do you have any questions? Anybody has any questions?
I actually have one, if I may. You, and again, I cannot thank you enough for really bringing out so many things.
Thank you.
Regarding this population and that relationship between the family and the elderly person. The one comment, though, I would ask about is the whole idea of the mass burials that were necessary as a result of many of the things you've talked about. First of all, our providers were horrified. And really, that's a whole other area of concern. But to even locate some of these patients that are deceased, and, you know, again, the timing of immediate intervention passed, but now what's going to happen maybe as people either return or come back and try to locate that whole system of how we had to handle the massive numbers that we were faced with. I don't know. Do you have a comment?
Absolutely, I agree with you. I feel that it's part of our responsibility to human dignity to include that burial of individual in part of and in their journey. And this is what it didn't happen for many different reasons. But I believe that things can be addressed, and this is a specific issue for the elderly, but it really applies to everybody. But I thank you very much. Okay, so that is, I believe the next slides are for Clivia.
Yes.
Okay, thank you, Clivia.
Thank you. Hi. Good afternoon. The next slide, that's not ours. Is that ours, Eugene?
Yes.
Okay.
I think Margaret has covered the most part in terms of group isolation. And I actually want to pinpoint.
Yiting, if you could speak up just a little bit, we can't hear you.
Oh, okay.
I'm gonna use my cell phone too, because my internet, my home internet is not too well, so I'm using my cell phone. So I just want to pinpoint the difficulties making the referrals. I know that as Margaret was mentioning with the APS, their website is not taking any cases, which is true. And last week I was able to make 2 referrals, but we have to email them first, and with the referral, like with your information, your phone number and email, and they will call you back to get the information from you in regards to which patient you wanted to refer. And so it's already, before the pandemic, APS referral already taking a long time to get back. And with the pandemic, it's just adding extra time. And in fact, the intake person was saying that they don't know if the caseworker is actually doing the home visit right now. I have not yet heard back from the caseworker regarding the patients that we referred. And so there's a delay in services. And with the home care, a lot of our caregivers we have in contact with for the last couple weeks, they either they are themselves contracted with COVID and unable to continue to provide the care for the family, for the seniors. And so they always ask about if possible to increase of home care hours. And when we deal with the insurance, I mean, the evaluation has to be done by the nurse doing home visits. And a lot of times the home aide right now, they also refuse to go to the home. I actually have a support group over the weekend, and it's a Chinese support group. And one of the caregiver was sharing that the A is refusing to, is worried about contracted the COVID, so she doesn't want to continue doing the role. So she resigned, and so now the agency is giving the caregiver an option. Either she's getting an English-speaking aide, which the family does not speak the language at all, or she just has to do it on her own. So the caregiver is actually stuck. So right now she ended up just doing it by herself, because having an English-speaking aide, which she cannot communicate with, it's harder than doing by herself. And so I think this is one of the caregiver stress that I mean, I think Clivia and I have encountered with. And I don't know if anything else Clivia wanted to add.
Yeah, basically, you know, like a lot of our caregivers, like Margaret did say, some of our families or the patients that we see don't necessarily have a support system in place. And sometimes that creates a lot of problems, because during this pandemic, sometimes people need a lot of services. And like Margaret had mentioned earlier, there's really no one that you can call or that you can follow up with because of the fragmented family dynamics. And sometimes the caregivers that we are working with are overwhelmed, because now they no longer have a home attendant working and, you know, taking care of their loved ones. They're working from home. most of them. They're also now caring for their children who are being, homeschooled at for the present time. And they're also dealing with their own feelings of, am I doing a good job taking care of my loved one, my children, and also trying to keep themselves safe and to be strong and like to stay healthy for them. So it really is causing a lot of stress for like the caregivers. What we recommend for caregivers is, like when you're working, when you're dealing with your loved one, try to be patient, try to be focused, and try to just maintain the same routine that you've had in place for the family or for the patient, because it does create a lot of anxiety, even for the patients, because if the patient was used to going outside to take a walk and now they can't do it, and they may question, they may ask, why can't I go out? Or they try to get dressed to leave the home. So rather than, yell at them and tell them you can't go out, just say, I think this is a time that we both need to stay home to be safe. And it's a real big issue because people can no longer go to their religious services, which we know in the Black and Hispanic communities is very, very important. Okay, so a lot of people do rely on that service for like once a week or something like that. They can no longer go to the senior centers. They can no longer go to the adult day programs, which they were used to. But the senior centers, for some patients, what they're doing is they're delivering food to the people if they can't do that. So that's one of the things that we always stress to the caregivers: try to register your loved one with a senior center, because at least during a pandemic or in some situation like this, they can at least get food. Once again, like Margaret mentioned, it's very important to get like a healthcare proxy in place, even a power of attorney. Those are things that Ethan and I, when we meet the caregivers for the very first time, we talk about with them and we review it. Next slide. Yeah. Okay, well, another thing that's important is for caregivers to be able to say to family members or, people that want to visit, no, now is not a good time. Some caregivers are concerned that, friends or family may want to visit, but we actually recommend to them that this is not the time for them to do so, because of the fact that you don't know if someone that's coming into the home has been exposed to the COVID-19 virus, and they can in turn get the patient sick, or they can get you sick as the caregiver. So. Next slide. Something that we always stress to the caregivers is that it's really important for them to make sure that there is a sufficient supply of medication for the patient. And if there's not, that they should definitely reach out to the doctors. We also tell them that some of the patients do have appointments that need to be kept, but they cannot because of the pandemic. So we encourage them to find out from their doctors and the providers, is telehealth available, so they can at least do some of the follow-up appointments via telehealth. What's also important, we tell them, is to make sure that you keep in touch with the patient's team. That could be the PCP doctor, the family members, or home care. A lot of patients have also opted to discontinue their home care during this pandemic because they don't want the patient exposed. And we are concerned about that, as well as the caregivers are concerned. So when the pandemic passes, are they going to reinstate all the hours that they have? Because there's a threat that hours are going to be cut across the board. And we also, encourage the caregivers, once again, like I said, stay healthy, rest, eat healthy food, trying to keep active. Exercising is really challenging for some of the families that we're working with, because they can't get outside. So we tell them, even if it's just to take a walk within the apartment, do chair exercises or things like that. Next slide.
I think that's all from us.
Any questions for Margaret, Clivia, and Eating?